You know that feeling, right? That nagging ache when you're really pushing yourself, maybe training for something. You sort of hope it'll just go away.
Happens all the time.
But sometimes it's actually a sign of something a bit more break. Well, sneaky. Today we're doing a deep dive into stress fractures.
Ah, yes, those hairline breaks. They can really mess up your plans if you're active.
Exactly. They're common, but maybe not always fully understood.
Yeah, definitely. And for this deep dive, we've gone through the material you send over on stress fractures, trying to pull out the really essential stuff for you.
So the aim is to kind of unpack what they are, why they happen, and importantly, how to spot them and maybe even avoid them.
Precisely. Give you the core knowledge you need, nice and clear.
Okay, let's get into it. Stress fractures. What are we actually talking about here? Define it for us.
Well, in simple terms, they're tiny little cracks, sometimes called breaks, but they're really small, in the bone.
Tiny cracks, not like a full snap from a fall.
No, exactly. That's the key difference. These aren't from one big traumatic event. They build up over time.
Yeah.
It's all about repetitive stress or overuse.
Like bending a paperclip back and forth.
That's a great analogy, yeah.
That-
Eventually it weakens. Same idea with the bone, just on a microscopic level. They're often called hairline fractures because they're so fine.
And where do they tend to show up?
Mostly in weight-bearing bones.
Mm-hmm.
Think lower limbs.
Mm.
The tibia, your main shin bone,
Right.
is a really common one. And the metatarsals, those long bones in your feet.
Okay, shin bone, foot bones. Makes sense.
And they can happen either because you're just doing too much, like ramping up training too fast, or sometimes because the bone itself isn't quite strong enough to handle normal loads, maybe impaired bone formation.
Okay, so too much stress or bone not coping well with stress.
Right. And typically you'll see pain related to exercise, often linked to a change, doing more, doing something different.
And these usually happen in otherwise healthy people. It's not like an osteoporosis fracture.
Generally, yes. These are distinct from fragility fractures you see with severely weakened bone. These are more about the load, overwhelming healthy or relatively healthy bone.
Got it. So what's the underlying reason? The etiology? Why does that repetitive stress actually cause the crack?
It comes down to the bone's natural repair process. See, your bones are constantly remodeling, breaking down old bone, building new bone. It's a balance.
Okay, like a constant maintenance job.
Exactly. But with repetitive stress, you get microdamage. If the stress continues, the breakdown process resorption starts happening faster than the building process formation. The damage accumulates faster than the body can fix it.
The repair crew just gets overwhelmed.
Pretty much. The bone's capacity to heal is just overcome by the rate of damage.
So what specific things tip that balance the wrong way? What are the main causes?
Well, the big one is increased physical activity, especially sudden jumps in intensity or duration, like going from couch to 10K training too quickly.
Right. Too much, too soon.
Yeah. Then there's poor physical conditioning. If your muscles aren't strong enough, they don't absorb shock as well, so more force goes through the bone.
Okay, that makes sense.
Also, improper technique in your sport or exercise, not getting enough rest between sessions.
So the bone doesn't have time to recover.
Exactly. And even things like inadequate footwear can contribute.
Okay, so it's a mix of factors. Now, what about specific risk factors? Who's more likely to get these? You mentioned grouping them.
Yeah, thinking about them in categories helps. First, you've got activity-related risks. High-impact sports are obvious: running, jumping, gymnastics, and, like we said, sudden increases in training.
Okay. Activity. What else?
Equipment and environment. Things like worn out or unsuitable shoes. Running on hard or uneven surfaces might play a role too.
Right, dodgy trainers on bumpy roads, not ideal.
Definitely not. Then there's nutrition and lifestyle. Things like vitamin D and calcium deficiency are big ones for bone health. Smoking also isn't great for your bones.
Okay, nutrition, lifestyle. What about the bone itself?
Absolutely. Lower bone density is a major factor. Conditions like osteoporosis or osteomalacia make you much more susceptible.
And hormones. I think I saw that mentioned.
Yes, hormones play a role. Hormonal abnormalities, particularly in women, things like irregular periods or amenorrhea absent periods, this links into the female athlete triad.
The triad: eating disorders, amenorrhea, and osteoporosis. That's a known combination, isn't it?
It is, and it significantly increases risk. Other things. Having had a stress fracture before makes you more likely to get another one.
Once bitten, twice shy, or maybe just more susceptible.
Something like that. Interestingly, a low body mass index, being underweight, is also a risk factor.
Really? You'd think heavier people might put more stress.
It seems counterintuitive,
Hmm.
but lower BMI can be linked to lower bone density and sometimes nutritional deficiencies too. Also, behavioral factors, like we said, pushing through pain. Ignoring those warning signs is a big problem.
That no pain, no gain idea again.
Yeah, not helpful here. And then there are demographic factors. Some studies suggest Black African ethnicity might have higher rates in certain contexts, despite often having higher bone mineral density, possibly related to loading patterns. Age is a factor too, as bone density tends to decrease later in life, and children's bones are still developing, so their BMD is lower.
Okay. And specific sports carry higher risks.
Oh, definitely. Basketball, gymnastics, track and field, especially distance running and hurdling, dancing, soccer, American football, particularly linemen and linebackers. Weightlifting, even rowing, though it's rarer, you can see rib stress fractures.
Wow, quite a list. So going back to what's happening inside the bone, the pathophysiology, you said microdamage accumulates.
Exactly, that repetitive loading creates tiny bits of damage, microcracks, in the bone structure. Normally, the remodeling process I mentioned, resorption formation, would clean up this damage.
The cleanup crew.
Right.
Yeah.
But if the stress is too much or too frequent, the resorption, the breaking down part, outstrips the formation, the building part. That balance is lost.
So the damage builds up faster than it can be repaired?
Precisely. The bone's repair mechanisms are just overwhelmed. The body tries to respond, you get inflammation, increased blood flow to the area as it attempts to heal. But if the underlying stress isn't removed, the fracture process continues.
Okay. Now, someone has this localized pain, worse with activity. But it could be something else, couldn't it? What's on the differential diagnosis list?
Good point. It's not always straightforward. Muscle strains are common, mimics pulling or tearing muscle fibers near the bone.
Okay, muscle strain. What else?
Tendinitis, inflammation of a tendon attaching near the painful area. Shin splints are a big one, especially for tibial pain. It's often hard to tell the difference initially just based on symptoms.
Right, shin splints are notoriously tricky.
They are. And occasionally, nerve entrapment syndromes can cause pain that might feel like it's coming from the bone.
So important to consider other possibilities. How common are stress fractures overall? The epidemiology bit. You mentioned UK figures are a bit uncertain.
Yet, pinning down exact prevalence figures for the UK is difficult. But we know they're common, especially in certain groups.
Like athletes.
Definitely athletes and anyone involved in high-impact activities. It's estimated they account for up to 20% of all injuries seen in sports medicine clinics. That's quite significant.
20%, yeah, that's a big chunk. Any groups particularly at risk?
Runners who clock up high mileage, say over 25 miles per week, are often cited. And military personnel, especially during basic training with all the marching and running.
Makes sense. That repetitive load again. Do we know where they happen most often in runners?
Yes, there's some good data on that. The tibia, the shin bone, is the most common site in runners, around 23–24%. Then the tarsal navicular bone in the foot.
That's in the arch.
Yeah, key bone in the midfoot arch. That's about 17–18%.
Mm.
Then the metatarsals, the long bones towards the toes, around 16%. The femur, the thigh bone, is less common, maybe 6–7%. And the pelvis is pretty rare, around 1–2%.
Okay, so mostly shin and foot in runners. Let's talk about how they actually show up the clinical presentation. What are the key symptoms?
The absolute classic symptom is localized pain. It gets worse with activity, specifically the offending activity, and this is crucial. It gets better with rest.
That activity pain rest relief pattern is the big clue.
It really is. You might also see some swelling over the area. It'll likely be tender if you press on it, maybe even feel painful right on the bone itself, and weight bearing usually makes it worse.
Okay. And we touched on specific sports having typical locations.
Yeah, it links back to the biomechanics. Track runners, navicular, tibia, metatarsals, distance runners, often tibia, fibula. Hurdlers can get patellar ones. Dancers, metatarsals, very common.
And the back ones.
Right, spondylolysis, that stress fracture in the spine, often from hyperextension. Seen in gymnasts, divers, football linemen, weightlifters, sometimes soccer players too, and those rare rowers' rib fractures.
So the sport can really point you towards a likely location. Is the onset always gradual?
Often it is. Maybe starting as a dull ache that just gets worse. But sometimes, depending on the bone and the activity, the pain can feel quite sudden. It varies. But generally, you're looking for that localized tenderness, swelling, and pain that ramps up with activity and eases with rest.
Okay, so someone comes in with these symptoms, high suspicion. How do you actually confirm it's a stress fracture? What investigations are used?
Well, the clinical history is paramount. Really understanding the person's activities, training changes, the nature of the pain that often gives you a very strong suspicion. You have to have a high index of suspicion, especially for those atypical or high-risk ones we'll talk about later, like the femoral neck or navicular.
Because diagnosis can be missed sometimes.
It can, yeah, because symptoms can seem vague early on or mimic other things like shin splints or tendinitis, so imaging often comes next.
What about x-rays? Can they see these tiny cracks?
Sometimes, but often not early on. Plain x-rays have pretty low sensitivity, especially in the first few weeks. You might only see changes later once healing has started, like a little bit of fluffy new bone formation.
So an early x-ray might be negative even if there is a fracture.
Exactly, which can be falsely reassuring.
Mm.
Other options include radionuclide bone scans. They're very sensitive. They'll light up where there's increased bone activity, but they involve radiation and aren't very specific about what's causing the activity.
Okay. Any others?
CT scans give great bony detail, but again, radiation dose is a consideration.
So what's the best bet?
MRI, magnetic resonance imaging. That's really considered a gold standard now. It's very sensitive, very specific for detecting stress fractures, even very early ones. It shows the bone edema, the swelling within the bone, often before a clear fracture line is visible. Plus, no radiation.
MRI it is then. So you've got the diagnosis confirmed. What's the plan? How are these managed?
The core principle is rest from the aggravating activity. Relative rest, really. You need to offload the bone to allow it to heal.
Stop the thing that's causing the pain.
Absolutely. Pain management is important too, usually simple analgesics. Activity modification is key, finding other ways to maintain fitness without stressing the fracture site, like swimming or cycling if it's a lower limb fracture. Appropriate footwear can help. And then a very gradual, carefully managed return to activity is essential.
Does it ever need like a cast or a boot?
Sometimes yes. For more severe cases or certain locations, immobilization with a cast or removable boot might be necessary to ensure proper rest and healing.
And I guess treatment depends on whether it's considered low risk or high risk.
Yes, that's a really important distinction. For low-risk stress fractures, think most metatarsal fractures, maybe posterior tibial ones, the approach is generally conservative.
Okay, what does that involve?
Typically rest from the causative activity for about 4 to 8 weeks, addressing any risk factors identified. We often encourage active rest, doing pain-free cross-training to minimize deconditioning.
Right, keeping fitness up without stressing the injury.
Exactly. Then rehab follows phases. Phase 1, maybe 1-3 weeks, is about relative rest, controlling pain and inflammation with ice, maybe anti-inflammatories initially. Phase 2, perhaps another couple of weeks, involves gradually increasing exercise, staying within pain limits. Phase 3 is the gradual reintroduction of running or the specific sport, slowly increasing load alongside strengthening exercises.
A staged comeback. Makes sense. What about the high-risk ones?
Yes. High-risk fractures need much more careful handling because they have a higher chance of complications, like delayed healing, non-union, or becoming a complete fracture.
Which ones are considered high risk again?
Examples include fractures on the anterior cortex of the tibia, the talus or navicular bones in the foot, the base of the fifth metatarsal, the femoral neck. These locations are under higher stress or have poorer blood supply.
So what's different about managing these?
Management is often more conservative initially, potentially longer periods of non-weight-bearing or immobilization. MRI is frequently used, especially for femoral neck suspicion, to guide treatment. Sometimes, particularly for tension-sided fractures like anterior tibia or femoral neck, surgery might be considered early on to stabilize the fracture and prevent displacement.
Surgery. Okay, so that's a possibility.
It is in some high-risk cases. Close follow-up is essential. Recovery takes longer, potentially 3 to 12 months, sometimes even a year or two if complications arise.
Wow, that's a long time out. So what's the overall outlook, the prognosis? Is it generally good?
For most stress fractures, especially the low-risk ones managed properly, the prognosis is generally very good. They usually heal well within weeks to months with adequate rest and that gradual return to activity.
But the key is proper management.
Absolutely. If they're ignored, not rested enough, or if it's a high-risk fracture that isn't treated appropriately, then the outlook is less certain, and you risk those complications we mentioned.
Okay, so prevention is obviously better than cure. What can people do to try and avoid getting these in the first place?
Prevention really revolves around managing load and building resilience. The number one thing is gradual progression. Increase the intensity, duration, or frequency of high-impact exercise slowly. Give your bones time to adapt and strengthen in response to the new stress.
Don't go from zero to hero overnight.
Exactly. Building leg muscle strength is also really important. Strong muscles act as better shock absorbers, taking some strain off the bones.
Makes sense. Anything else?
Always warm up properly before exercise and include stretching. And listen to your body. If you start getting localized bone pain during activity, don't just push through it. Get it checked out early.
Okay, listen to your body. What about gear and surfaces?
Try to minimize abrupt changes. Don't suddenly switch to radically different footwear or start running exclusively on a much harder surface. While the evidence on specific running shoes preventing stress fractures is a bit inconclusive, sticking with what works for you and replacing worn-out shoes is sensible.
And smoother surfaces might be better.
Potentially slightly lower risk on smoother, more forgiving surfaces, yes. Another interesting tip is maybe planning a slightly easier week, perhaps around the third week of a new or intensified training block, as that seems to be a vulnerable period for accumulated stress.
Ah, like a planned deload week.
Kind of, yeah. And finally, general bone health measures, ensuring adequate calcium and vitamin D intake, avoiding smoking, limiting excessive alcohol. These help maintain good bone density, reducing underlying risk.
Great tips. Lastly, what are the potential complications if things don't go well?
Well, as we touched on, delayed healing is one the bone just takes much longer than expected to mend. Non-union is more serious. That's where the fracture fails to heal completely.
The bone fragments don't join back together.
Correct. That can lead to chronic pain and dysfunction. Some people develop persistent pain even after healing appears complete. And the biggest risk, especially if someone keeps stressing the weakened bone, is progression to a full, complete fracture.
Which would be a much bigger injury.
Much bigger, potentially needing surgery, and a much longer recovery. And again, these complications are more common in those high-risk fracture sites. It just underscores why getting timely medical advice, an accurate diagnosis, and sticking to the management plan is so critical.
Definitely. So to sum up, stress fractures are these overuse injuries, tiny cracks from repetitive load overwhelming the bone's repair system, loads of risk factors from training errors to nutrition to biomechanics. The key symptom is that localized pain, worse with activity, better with rest. MRI is usually the best diagnostic tool. Management is all about rest, modifying activity, and gradual rehab, but high-risk ones need extra caution.
That's a great summary. Understanding these often subtle injuries is just so important for anyone who's physically active, whether you're an elite athlete or just enjoy exercising regularly.
Absolutely. So, thinking about everything we've discussed, perhaps a question for you, the listener. Considering this information, what adjustments might you consider in your own activity or training routine to help minimize your risk of stress fractures?
Something to mull over. And if you are looking for more resources, perhaps for revision or just deeper learning on topics like this.
Yes, definitely check out PASMUSR.com and also freemsra.com. Lots of really useful material there.